Okay, we are running short of time. We'll go for the second or third presenters. Professor Karl Herbert is going to talk us about the laser flare photometry and geographic workup for posterior uveitis. Professor Karl is visiting us from Geneva, Switzerland. Professor Karl.
First of all, I would like to thank for the invitation to the organizers. First time for me to be in Jeddah, and I could already see that it is a beautiful city. Do I need to do something for the slides? Okay. This is a young girl. She's 8 years old, and she has been operated of her cataract, GIA, juvenile idiopathic arthritis related uveitis, and the situation is catastrophic. Ahmed, would you put an IOL in this patient here? She got 2 IOLs, and the situation is really very bad. You know, she has 3/60. Laser doesn't work. Okay. Anyway, 3/60 and finger counting on the other hand. The uveitis specialist, which was seen, said that you should take out these IOLs. Everybody agrees? Of course not. If you take out the IOLs in this situation, you have a phthisis after that. So she was under 1 drop daily of Pret Forte, you know, prednisolone 1%. So you tell me, why only 1 drop? Because there were no cells in the anterior chamber. So no cells. In the past, it meant no active inflammation. So what we did is put her under maximum treatment, which means local and systemic steroids. And in children, you need not 1 milligram per kilo, you need 1.5 or 1.7 milligram per kilo. Azathioprine and flare, still doesn't work, flare went from 400 to 260 in one eye, and from 292 to 124. Vision increased little by little. So, no cells does not mean no active inflammation, because nowadays we have a precise measurement technique of inflammation in the anterior chamber, which is laser flare photometry. We are now in an era of uveitis which is a science, a clinical science, which is as precise as glaucoma. You know, 20 years ago we were very jealous of glaucoma people because, you know, they could measure very precisely everything. Now we can do this also in uveitis. This was shown for laser flare photometry since about 25 years. Still, the technology is not used widely yet. To take an analogy, the precision of the Proctor, or maybe now Sun, grading system in uveitis can be compared to digital finger evaluation of intraocular pressure. Today, no glaucoma center would consider to follow intraocular pressure by this method. Now, this is how you do finger grading of pressure in what is called digital IOP pressure measurement. I mean, this is comparable to what we used to have to measure intraocular inflammation by the Sun Proctor grading system. 1+, as you can see on up there, 2+, 3+, etc. No serious study can be done on anti-inflammatory substances in cataract or in any situation without using precise measurement method which is given to us by laser flare photometry. Laser flare photometry is giving us precise information on high flare situations. Like in this case here, oh yeah, the screen is absorbing the laser. Sorry. Here we have a patient who has Behçet's disease, treated by immunosuppressive treatment, and then we go down with treatment, and you can see here where the white arrow is, there is a slight increase of flare. At that time, we did not know yet that this was a serious alert for a recurrence, which happened a few weeks later, as you can see, with the peak of inflammation. Flare is also useful in low flare situations, in situations where your human eye cannot make a difference, but where the machine is making the difference. This is a young Indonesian girl. She was diagnosed in Singapore by our colleague Sun Pek Chi as Behçet, and this was a correct diagnosis. However, she was under cyclosporine, and we decided to switch to mycophenolate because of renal problems. So first of all, we went down with cyclosporine, and what happened? Flare increased from 5.2 to 20. So is this preoccupying? Yes, of course. And when you do a first in angiography, you can clearly see that there is a recurrence. So we went up again with cyclosporine until mycophenolate, which takes a few weeks to act, was taking over, and very quickly the situation was controlled by a decrease of laser flare photometry and a restitution of first in angiography. Let's go over here. This is a patient which had a focus along the inferior arcade. So the initial suspected diagnosis was toxoplasmic retinochoroiditis. The patient was put under antibiotics and corticosteroids, and what happened? Lesion progressed. So this was an atypical herpetic lesion, retinitis. We started antiviral treatment by suspecting this diagnosis, and laser flare photometry told us, before we could see it clinically, that this was the right treatment and hence the right diagnosis. So this is giving you anticipated information on the diagnosis and the clinical evolution. And sure enough, after antiviral treatment, flare went down, confirming the diagnosis. Here is another patient who had PORN, progressive outer retinal necrosis in one eye, which was treated with antivirals, acyclovir. Nevertheless, despite this treatment, you can see that inflammation, flare, is going up. So this is a patient where this antiviral was not sufficient, or this virus was resistant. So the patient was put on ganciclovir, and you can see that under ganciclovir, before it was clinically apparent, there is a decrease of inflammation, telling us that this was the right treatment. On top of this, the other eye had peripheral lesions, so this was BARN, in fact, bilateral acute retinal necrosis, where you can see that as soon as ganciclovir is given, subclinical inflammation is going down, vision is going up again. So this is giving you an idea of the precision, the security laser flare photometry gives to the management of uveitis in the center. Of course, this is used in uveitis specialized center. Why should we deprive ourselves of this technology? So in summary, laser flare photometry for uveitis represents a substantial technological progress, transforming flare from a qualitative to a quantitative and objective sign, and making flare, rather than cells, the preponderant parameter for the evaluation of intraocular inflammation. Today, it is not thinkable for a center specialized in intraocular inflammation that performs clinical studies to manage without laser flare photometry. As I said at the beginning, this is one example of the precision we have reached today in uveitis with new technologies. Second topic, angiography. Everybody knows fluorescein angiography. It is giving us information on the superficial parts of the fundus. We know exactly what is the information we get from fluorescein angiography. I will pass over this. However, there is now another methodology in ocular angiography, which is indocyanine in green angiography. And typically, only two conditions when the patient is at presentation can be diagnosed only with fluorescein angiography. You never know whether, on top of what you see, you never know whether there is a choroidal involvement. Two conditions like Behçet and intermediate uveitis of the pasponitis type, you don't need indocyanine green angiography. This is preponderant inflammation of the retina. In most other common conditions, occult choroidal involvement cannot be excluded when you see the patient first, and if you think that angiography is necessary. A priori, you cannot exclude this. This is a, come on. Yeah. You can see this OCT. I mean, you're very experienced in these kind of pathologies. Of course, the diagnosis here is VKH. Treatment of VKH, acute VKH, is very easy. High-dose steroids. And if you give this, very quickly, things get back to normal, both on the OCT and on fluorescein angiography. So the situation seems to be under control, but the patient still has headaches. So would you step up the treatment? She's now under prednisone, cyclosporine, and mycophenolate. Let's see what EDI-OCT is telling us. EDI-OCT, not so much difference, you know. Not very useful for acute follow-up. Now let's look at ICG. This is the situation on OCT and on fluorescein angiography. Situation is normal. On ICG, situation is not normal at all. You can see on the left here a lot of choroiditis. If you treat this patient with an additional immunosuppressive like Remicade, in 6 weeks we go from here to here. So you can imagine again what precision you get to follow and treat choroiditis using indocyanine green angiography. Without ICGA, ongoing choroidal inflammation would never have been detected. Moreover, the determination of the therapy that was active in this case, namely anti-TNF-alpha, would never have been found so quickly. EDI-OCT for acute follow-up is not useful. For chronic follow-up, for long-term follow-up, it is useful. Again, like for laser flare photometry, how can a uveitis specialist deprive himself of this precious instrument? This is a case of back, front. Yeah. This is a case of VKH, looking at EDI-OCT on the line above, looking at ICG on the line below. You can see that EDI-OCT is not detecting subclinical recurrences which are detected by ICGA. This is a schematic view of what is happening in VKH. In the prodromal phase of the disease, you have subclinical inflammation of the choroid, which is shown on the right there. In the clinical stage of the disease, this choroidal inflammation is breaking through into the retina, and this is what you see on the right there. Before this happens, if you do ICG, you can already see the subclinical inflammation of the choroid. Now, what is this disease here? You don't see this very often here, but everybody has seen this in textbooks. This is birdshot. Now, what is this disease here? This is birdshot. But it cannot be called as such because the required criterion of presence of at least 3 peripapillary birdshot lesions inferior or nasal to the optic disc in one eye is not fulfilled. So you cannot make the diagnosis here unless you use ICG. ICG is going to allow you to make the diagnosis in birdshot early, before you have birdshot lesions in the fundus, And you can treat Burchard at this stage and avoid the appearance of Burchard lesions, deep pigmented Burchard lesions. So we have to make new criteria, but I will talk about this afternoon. The same is true for VKH. If early, sufficient, and sustained treatment, including corticosteroids and non-steroidal immunosuppression, is given, sunset glow fundus can be avoided. And this was largely shown by Professor Abu el-Asrar in Riyadh. This is a 45-year-old female patient seen for blurred vision and floaters. Vision is still good, visual field changes, etc. And this is what you see. Hypofluorescent dark dots, HDDS. And this again was revealed by ICG. This was a Burchard case. But I will talk further of this afternoon.
One minute more.
Okay. So, investigation of a case of posterior uveitis for which angiography is deemed necessary is not complete unless ICG is performed. And there are two exceptions, which are Behçet's disease and pars planitis, intermediate uveitis of the pars planitis. In conclusion, the tools we have nowadays to diagnose and especially to follow our uveitis patients make our specialty a very desirable one, but this is the time where we are really able to exactly control what is happening. But to do this, we need to use these new tools, and this is far from being evident. Thank you very much for your attention.